I've got flexion to obtain at that joint, I could put the whole thing in flexion. That'd be okay. It would take up the slack with the ligaments, and I could use the locking positions for that as well. But it would seem to me to be kind of a good idea to put this into extension below, so the extension resists the flexion. And then I say to myself, now, how in extension do I resist right rotation? Well, obviously what I've got to do is to side flex her to the right, which produces rotation to the left, which resists rotation to the right as I move down into that. So in actual fact, just, you know, to just throw a spanner in the works, as I say, or a wrench in the works here, what we've got here actually is the coupling, isn't it? That's the couple movement. When I do that and it rotates this way, it becomes locked though with this rotation tries to get into it. It's locked for that rotation. But we create it by putting it into the coupled movement, which is side bend here, rotates that. And this is sometimes in Olaf's pictures you get a little bit confused. You know the little diagrams he's got with the little keyhole sign, meaning locked. You look at the two combinations of movement, you think that's not locked, that's the coupled movement. What he's talking about is it's locked for the movement he's trying to do in that top lever. So that if I try and get into rotation down here, it immediately locks for that. So I think that if we side flex to the right, it rotates to the left, which means it's resistant to right rotation. It's locked against right rotation, if you like. So the next thing I'd like you to do is you can just sit down for a second, all right, just yourself, and on a piece of paper you can write in a little problem. All right, and I want the problem to be about T2, T3, or T1, T2. So we've got some lever below it, and we've got some lever above it. L2. L2, what did I say? T2. Oh, let's finish the afternoon off. Let's go home. Okay, so L2, okay, L2. So that we have got a bit of a lever below and quite a long lever above. All right, so you create what the stiffness is, and I'd like your partner to be able to use a lever if they want to work from the top lever or if they want to work from the bottom lever. And I want you to have a go at double locking in lying. This is your big moment, Sandy.
In lying down.
In lying down, yes.
So we create the problem.
You create the problem. So, and then give it to your partner. And we'll work with a different partner. So you go look round for somebody who's looking fragile and push your piece of paper into their hand and say, get on with that. Okay, did you have anything that needed to be done? It's a very interesting thing that when we're doing all of these mobilizing techniques with double locking and goodness knows what all, it is incredibly more complicated than manipulating. Manipulating, lay down, painful side on top, are we going to do this, 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 that? And all of this stuff, this complicated stuff, is sort of for mobilizing. In principle, manipulation becomes really a lot simpler. Let's just consider for a minute the kind of classical case that you could manipulate. What would it be? This is the ideal profile for manipulation. This fellow here. Okay? That there is no previous history. That he bent forward or bent or moved in a position and he got a click or he got a feeling in his back that something had been displaced. The pain is very local. It has no radiation. When you look at the dural signs, they are negative. When you look at the neurology, it is negative. And so here we've got somebody who's just got this very local pain in his back and he feels that his back has locked. What would be the standard procedure for this? If you went nearly anywhere in the world, perhaps not with some manual therapists, they may go through this great long rigmarole, I don't know. But if you went most places in the world, they'd just tell you to lay down there and they would do a little release. or an adjustment or a manipulation, however it's going to be called. What is the features of this sort of typical joint block for a start-off? It has a number of characteristics, doesn't it? And we talked about these the other day. What do we manipulate? Anybody know? Well, maybe. Anybody else got any ideas? You manipulate the manipulatable lesion. How do you know that it was the manipulatable lesion? Because it responded well to manipulation. This is what it largely is. And you're looking for the profile of the manipulatable lesion, and it's this. And we could add to it Klenian's sort of profile, which is this one here, for chiropractors, because Klenian is a chiropractor in Australia, who said that all of those things that I've spoken of are true, but what he would do is he would go a stage further and he would more identify the lack of neurology and the lack of dural signs by actually stating this, that the straight leg raising would not be significant. Certainly it wouldn't be limited under 45 degrees. That we would not have a contralateral straight leg raise sign. Why? Because there is a 95% or a 90% chance that that is pathognomonic of an L4-5 disc lesion. If we lift one leg and it causes sciatica in the other leg. That there should be absence of Dayer's sciatic nerve stretch. What's that? It's sitting down unsupported, taking the leg up into a straight leg raising position, and then doing the bowstring test. That's sciatic, that's Dayer's sciatic nerve test. You shouldn't have prone knee bend restriction, because here again we're looking at 4 or we're looking at discs at 2 and 3. And Desjardins triad. Chiropractors are kind of keen on very often naming names, which they are in Europe too, like somebody's test. Over in North America we tend to sort of call it by the test, but these are terms that still exist. And what's Desjardins triad? That we don't send pain into the leg in coughing, sneezing and straining at a bowel movement, like Valsalva, sending pain into the leg. So in the absence of this and the presence of that, this is the manipulatable lesion probably. And what are the characteristics of this manipulatable lesion as spoken by Lewitt or I mean, look at this. I mean, we're into all of these very vague terms here. Non-pathological, reversible mechanical problem. There'll be local spasm and tenderness, because these are the tissue texture abnormalities of a joint dysfunction. Movement is not restricted in all planes of movement. If it's all directions, we've got pathology probably. Movement is restored almost immediately after HVT is applied. High velocity thrust is applied. But we better be doing this to a manipulatable lesion, else we might find movement is worse after HVT is applied. And the last one, distraction as a rule gives relief. Now, what are the possibilities? Sandy gave us one, but here are other possibilities as mentioned in Rahlmann's article that you read the other day. Meniscoid entrapment is a very, very good scenario. Secondly, displaced intervertebral disc fragments. And we know now that you can get displacement of a fragment of disc within the disc itself. So we can get fibers within the annulus sort of bunching up by tearing within the tear of the annulus. So it may not be obvious from the outside. Segmental or intersegmental muscle spasm. Can we have that as a primary problem as opposed to secondary, say, to a meniscoid entrapment? It seems it's possible to get this. that in some way the movement in a particular plane has created a problem in the neuromuscular spindle mechanism, the gamma alpha, or the gamma alpha relationship. So that when we get to this position each time, we get muscle spasm because it fires off the neuromuscular spindles at that particular level. And the last thing is a periarticular connective tissue adhesion. Is it possible to think of this as an immediate onset thing? Not as it's stated there, but how about this as a scenario? Okay? Sometime previously in my fit days, I exercised and I did a little bit of damage to my back. And time passed and I got a little less enthusiastic about doing things, as I have done actually. And so you find you go to seed. Then you go to your physician who says to you, I think we'd better have a little look at your blood work. And it comes up that you've got your HDLs are right down here and your LDLs are right up there and your cholesterol is kind of flashing black lights like this, do something about this. So he says, you know, all you can do at the moment is kind of take an aspirin every other day, but you're like a walking time bomb here, your arteries are silting up. So you think, geez, I better get going, I better get exercising again. So what we start doing is starting to do all these movements, and now the damage that we did before, which has been protected by my stiffness, I now get to the point in that joint range where this little articular adhesion, which has been protected by my total stiffness and lack of activity, now is waiting to be pulled on. And so I've been doing, oh geez, because perhaps that day I didn't displace a meniscoid or do this, but perhaps I reached my periarticular adhesion, which had been created sometime previously, but had not been threatening it by my lack of activity over the last several years. So I think it is possible to get these. You can't imagine it just developing like that and stopping it, but it may be that you've just revealed it again. And I think that's probably quite a good scenario to look at. So we have these things here, and the three that we're going to be looking at, I suppose, a little bit more, would be these three. Because as we looked, there's always going to be muscle spasm around here. Is it the problem, or is it part of the problem? I think most of the time it's part of the problem, but it could be that this is the problem. And it's very interesting to me that any of you here, I don't know whether you felt this, but if you've got some spasm, Barbara would be kind of quite good here. She's got a joint on that right-hand side, and it would be very interesting to just palpate it very gently, see if you could release it, and if you could, has that spasm gone? Like right now, has it gone? And very often you find it has. It's like instantaneous.
I have two questions.
Okay.
Do you consider the annulus part of the periarticular connective tissue structures that could get adhesions in them? Or do you look at it as being the set?
No, I think the annulus is a quite distinct structure, and I think round the annulus we have loose connective and areolar tissue, which would be the pericapsular or the periannular structures. And I think if you did a morphology of sectioning from one to the other, although there's similarities in the way that the collagen is in there, because there's collagen tissue, the disposition of the collagen within the annulus would be quite characteristic, as opposed to the rather more varied form and much less well-developed form of the periarticular structures. Now, there must be a reason for asking that.
Oh.
In other words, are you setting me up? No. Yeah.
When you talk about that, there was some, I'm not as well read as you are,
Yeah.
but there was a study they did on Boeing employees, and the only
Yeah.
thing that could predict if someone was going to have back pain
Yeah.
was if they had back pain in the past.
Yeah.
All this,
Yeah.
straight leg raise, all
Yeah.
these things.
Yeah. Yeah.
So to me, that seems to say something like periarticular connective tissue adhesions
Yeah.
are a lot of what's causing
Yeah.
this back pain,
Yeah.
because we teach people not to move,
Mhm.
but then at some point in their life they move in that
Yeah,
way.
sure.
That gives them the back pain. So
You could go with 4. Yeah, you'd move it up to mu. Okay, that's fine.
That, and so no, I was just wondering if, you know, if the annulus can get adhesions and scar tissues in it like any other ligament. You just look at it as a ligament that surrounds the whole body.
Yeah, it's avascular, isn't it? So you kind of wonder about the reaction, but certainly within the annulus itself, I mean, you do get autoimmune reactions, there's no question. And Paris has got some pictures of kind of like healing taking place within the annulus itself.
And then as far as the true second question when we started out was that when you manipulate Barb and her muscle spasm goes away.
I'm not saying it would, but I'm saying that very often this is quite clear that it does.
And what is your rationale for that happening? Is it a neurophysiological
Yes.
thing?
Yeah.
Freeing up the nerve, or just that overflow? Or?
No. I'm into entire speculation now, Sandy. Entire speculation. But you know, what the hell? We can get into entire speculation. I don't really know what the answer to this is, but this is what I sort of think might happen on this. That okay, here we've got the spindle, and here we've got the extra spindle fibers. Okay, and we've got the annular spiral ending coming up here to an alpha loop and back to the extrafusal fibers there. All right, and of course it's the extrafusal fibers that we're feeling in spasm, not the spindle. Now, what I'm saying is that when we look at the spindle is set, isn't it, to be a particular length. And this length of the spindle is controlled by the gamma fibers here. All right? And in having a very nociceptive input from all sorts of structures within the muscle or perhaps within the joint as well, what we're getting is an increased activation in this anterior horn cell pool here, which is creating a lot of problems down here in terms of spasm. All right? Now, what happens when we come along, and this is totally speculative, no idea whether this is true or not. What happens when we come along and we manipulate this is that this is under tension, okay? And this has got spasm, and this is set now to be in parallel with these extrafusal fibers, so its tension is set fairly high. We come up here and we suddenly do a very sudden little stretch on that movement, which means that this thing here fires off into the central nervous system here a mass of information. And the segment, in some way, through perhaps extrapyramidal control, realizes this is totally inappropriate. And so what happens is that this facilitated part here is damped by perhaps extrapyramidal activity, and this is taken down to a low level, and this immediately drops this activity to a much more less palpable level. So I think it's to do with a sudden stretch, massive bombardment which is inappropriate. The central nervous system cuts down on this massive bombardment and sends this into a much more quiescent phase, and it's like instantaneous. It's bang, and you feel, and it's gone. That's remarkable to me, absolutely remarkable. And it's so constant that. More, I must say, in the cervical spine, because I think the muscles there are a little easier to feel. And perhaps also they've got a much higher density too of neuromuscular spindles to muscle fibers as well. But in the cervical spine it is very, very easy to feel. So that's what I think happens, but I haven't got a clue whether that's what it is. But nobody's ever come up with a better explanation than that one, you know, that I've ever heard. Of course, if we're sort of thinking about the meniscoid, which you had a look at the other day in terms of, perhaps if you got round to it, the articles by Bogduck, and anyway that they will be waiting there for you. That the other sort of very, very nice explanation that was put forward by, once again, Bogduck and Gwendolyn Jull was this, that if we look at, and this is taken from Tomies and Bogduck's book here, if we take the picture here, we can see the form of the meniscoid in this part here, and that as we move into flexion, let us say, the meniscoid moves with the moving facet, and it keeps the facet plates touching an appropriate tissue, which is the meniscoid, and not touching the synovium. All right, so we get forward, and as you can see here we've got the fibrous meniscoid. Here we've got a little adipose fat. Here's the fibrous meniscoid. Here's this connective rim around the joint here. This is the articular cartilage, and these should be sitting in here. Now then, if we take to the bottom picture, all right, we bend forwards like this, and that meniscoid should, in actual fact, slide with the forward moving facet like this. And generally speaking, as we move back into extension, it will come back and slide between the joint surfaces. Now, the thing that we have to sort of appreciate here is that the capsule doesn't attach exactly to the articular rim here. It attaches a little distant to the rim, so that we have a little sort of capsular recess here. So I go forward like this, and then I suddenly come up, and particularly if this is a hypermobile joint, all right, and what happens is that this little meniscoid, instead of going between the joint surfaces, buckles up in this intracapsular recess and stretches the capsule, which is highly innervated. So what do? We go back down again. We try and keep it in this position where it's not causing any problems, and we walk along like this. Now then, you arrive at Bill's Miracle Emporium, okay, walking like this, and he says, lay down on there and I will fix this. And what does he do? He does the $1 million roll, okay, because he drives a Toyota Land Cruiser, so he must be $1 million roll kind of guy, all right? And what happens with the $1 million roll on the top side? What happens to that facet? It gaps wide open. So what happens here is that this gaps open like this, disengages that from that point, it slides back between here. Oh, that's worth $500, Bill. Please take my check. It's quite all right, David. You put your money back in your pocket. All right. So here we are, and that is kind of a good explanation of the meniscoid. And I think this seems to fit the bill. Now, what happens within the disc? Desairs has got sort of explanations of disc material changing. Matthews, who worked at the St. Thomas's Hospital, took pictures of, epidurography before and after traction with distraction and showed that there was some change in the sort of irritability. But then we've got the whole business with Cassidy showing that most of these x-rays don't change at all, and you've all heard those stories about what was it called, that auto traction that was very popular with Natchev some time ago, that here was patients that they took CAT scans, showed big bulges, put them on the thing, the auto traction, they all straightened up, took them down for a CAT scan, and there was, disappointingly, the thing looked exactly the same, but the patient wasn't the same. And so there's obviously something goes on here which is not to do entirely with the place of a little bulge and the irritability of that bulge on the nerve. And in some way we've got to try and rationalize how manipulation does this. So this is the sort of system. And when we think about all these kind of complicated double lockings and goodness knows what all, which is very important that we do, because we use some of the principles, but actually what we do at the joint is usually dead simple. Do we distract it? Do we side flex it? Do we extend it? Do we side bend it and extend it? Or do we rotate it? That's what you're doing at that segment. And it just depends on all the complicated things here as to how rigid you make the levers. If you want to work through the top lever because the bottom lever has got some hypermobility in it, you'd obviously put it into its non-congruent positions because you don't want it flopping around when you're trying to get down to moving this bone as against that bone. And that's what manipulation is. It is so much simpler in the whole of what we do and the whole of the form. And so I'm going to finish now in 5 minutes. So just bear with me for 5 minutes longer. I'd like to just do this with you just this afternoon. So you can take it away with you and we can start on this first thing in the morning and perhaps just start on just looking at those important points when you're very fresh in the morning. Although you did quite well on those movements, I must say, considering how complicated it is. I'd like you to imagine that you're standing now in front of the patient, okay? And we're just looking over their backs here. Okay, there's the belly button there. Like that, all right? And this is like the standard manipulating position. This is the buttocks, okay? This is the belly button here, okay? The legs would be down here. All right? Well, the buttocks would be on. We're looking at, this is the back. I mean, you don't want me to put all the sort of structures in here, do you, on the front side here? Okay, here we are. Here's the pubis. Okay, and we kind of remove that if you like. Just go straight down there. This is the pubis. So we're looking over the patient. There's the pubis there. All right, and in the standard position, we're standing here, aren't we?
Yes.
Okay, this is the position. Okay, this is the position. All right? And this is the classical position. And what do? We take the shoulder back and we bring the pelvis forward. That's the classical position of manipulating. All right? And when we've got the patient, and I'm standing at the posterior aspect, which I would normally stand there, okay, so I'll put it here for your benefit. So we're in this position like this. All I've got to decide to myself is, how can I produce all the movements that we just spoke about? If we're going to produce rotation, I'm going to be taking the shoulder back and the pelvis forward. What does it do at the segment? We've got to ask ourselves that question. On the upper surface here, which is the right side, it's going to gap those joints. On the lower surface, it's going to impact them, so they're going to become the axis of rotation for that particular joint. If we do that, there's a propensity when these joints gap to happen. What happens at the intervertebral foramen? It gets smaller. But in the way that I do this, which is to sort of rotate and pull like that, I'm going to produce a little flexion and a little side flexion to the other side. And what does that do to the intervertebral foramen? It opens it up again. So the $1 million role, we're all saying, oh, geez, I shouldn't rotate and all this business. Probably all over the world, millions of these are done, and there are not millions of people having a backache converted into a raging disc prolapse. So perhaps our worries have been a little bit over-exaggerated. And that's, I think, what Cassidy is being saying. So if I could just now bring it round to so that it's facing me here, and we think of this standard position, which I'd like you to think about, because this is what's